Welcome to AETCM, the Emergency Medicine Channel. Shall we start?
Yeah.
A 74-year-old male presented to ER with history of altered behavior, irrelevant talk and decreased food intake since 1 week. On initial 10-second assessment, airway patent, no secretions, breathing, air entry bilaterally equal, respiratory rate of 18 per minute, saturation 100% on room air, circulation BP is 160/80 millimeters of mercury, pulse rate is 87 per minute, disability, patient conscious, obeying commands, pupils bilaterally equal, reacting to light, exposure, patient is afebrile, GRBS is 160 milligram per deciliter. So we had adjuncts to primary survey, we had taken a VBG, there was no acid-base imbalance, sodium was 118 and potassium was 3.6.
Potassium was 3.6. Okay. So 75-year-old gentleman who has come with altered sensorium to the ED. So that is their presentation. Right now he is hemodynamically stable. He has got a GCS of, what was the GCS?
E4, V5, M6.
E4, V5, M6. That's a 15/15.
Yeah. So obeying commands.
So obeying commands right now is, then we can say is conscious oriented. Right now there is no altered sensorium as such from the GCS that you are telling. Okay. So an elderly 75-year-old man coming to the ED with altered sensorium, what will be your top priorities of differential diagnosis? I don't want to see what happened to this patient. What are the things that you will consider in your mind? A 75-year-old man coming to ED with altered sensorium.
Any cerebrovascular accidents, any bleed or anything?
Okay, the most common things you say first, hypoglycemia. Okay, hypoglycemia, the first one, you have ruled out a hypoglycemia. Then hypoglycemia, you said cerebrovascular accident. Altered sensorium with this presentation, cerebrovascular accident, maybe I will keep it down the line. It will not be my top priority. So it will be a little bit on the lower side. So alter, then what will be the next thing?
Hyponatremia.
Electrolyte imbalances, hyponatremia. Any of the electrolyte imbalances, among the most common one is hyponatremia. Okay, I'll keep as the second one. Third one you said regarding infections. So can fever present with altered sensorium?
Febrile delirium.
Febrile delirium. So that is one of the most common elderly people coming with fever, febrile delirium. You just correct the fever, they will be back to normal. So that will be my third differential. Fourth. Then fourth. Okay, you can put it as any of the metabolic rather than their hyponatremia. It can be a uremic encephalopathy. We don't know what is the background of this patient. So that is the next step. Can we have another CNS infections? You said regarding infections in total, it can be a CNS infections also. So they can come with altered sensorium, maybe an encephalitis, viral encephalitis. What is the next most important thing? In ER, we usually miss this. We don't think that is a reason for an altered sensorium. Most common you have to remember is hypoxia. So hypoxia, maybe the patient may be breathless, and because of that hypoxia, he might be having an altered sensorium. So just an hypoxia, they can come up with altered sensorium. Just keep those things in your mind. So the patient is in sepsis, gross sepsis, they will not be allowing you to keep the oxygen mask. They will be restless. Rather than calling it as an altered sensorium, they will be more agitated. That will be the presentation that you need to consider. So hypoxia also can present in a similar way, but they will be more irritable and they will be more agitated, like sort of a behavior. Like where you have a PCO2 buildup, then they will be more drowsy. So whenever you have hypoxia, you can easily miss a hypoxia. You don't think that hypoxia definitely, that is one of the worst signs to have an hypoxia, an irritable patient with hypoxia. You start on oxygen, maybe an NIV, he might hold on, but that patient, I will give it as a priority and he should be in your red area. So that patient can deteriorate at any point of time and he can crash. Especially these sort of patients who have got this tropical fevers, Weil's disease, significant gram-negative bacteremia and sepsis. So they can deteriorate at any point of time. So there may be presentation, they will not give any history of fever or anything. Maybe some just generalized weakness, tiredness, they will come. But hypoxia also one of the reason why you need to keep in your mind. Then as you said, cerebrovascular accident. Altered sensorium, it's a broad term. You can have hyperactive and hypoactive also. So altered sensorium, the patient is not in his normal sensorium. So it can be agitated or the patient can be drowsy. So maybe drowsy, we will more into favor of an intracranial hemorrhage. But altered sensorium, like in the last case when we had an acute stroke, I have told you, when the patient can have, like he is suddenly forgetting the way to his house. So that might be the presentation. Like a stroke chameleon, they can present. So that is the another differential diagnosis that you need to keep in your mind. So these are the most common reasons that you will see a patient with a simple thing. You can have about CNS infection or a generalized infection that is affecting the brain, or any of the electrolyte or metabolic abnormalities that is affecting. So these are the spectrum that you should keep in your mind, and you should be, our evaluation should be oriented towards that thing. But suppose it's a young male, anything else that you need to, young male or maybe a 40 or 50-year-olds, I don't saying denying the fact a 75-year-old cannot have this, but suppose a young male is coming with an acute episode like this, he's otherwise okay, that's what the mother is saying. What are the most, another thing that you need to keep in your mind? So acute behavioral disorders, so that is one of the new spectrum of disease that is coming up to the ED. So acute behavioral disorder, especially any withdrawal to any of the agents that they are having. And another thing, any age group you need to consider is alcohol withdrawal. So that is the topmost priority you should keep as a differential diagnosis. But they will be again more irritable, tremors and all those things. They can go into wernicke's encephalopathy and all those things. But acute behavioral disorders, you need to be very, very careful. And what is the drug that is specifically recommended for acute behavioral disorder? It is ketamine. It is ketamine. Right now, it is recommendation is ketamine. But that spectrum of patients, I think we are missing those group of patients. We are not thinking in terms of that, but definitely as the cases are increasing, we might be seeing more number of tramadol overdose. We had a patient with tramadol overdose who was regularly taking tramadol, who's taking on some other over-the-counter drugs, or maybe some other agents that the patient is already on, and they can come with acute behavioral disturbances. So maybe you can try with oral haloperidol, oral benzodiazepine, for that is for an OP purpose. Maybe they are coming to the ED. Ketamine is one of the preferred agent for such group of patients. So that the problem in this group of patients, what they will be agitated. They have got a lot of sudden catecholamine surge. Like what you see in pheochromocytoma, they will be agitated, hypertension, tachycardia and all those things. And suddenly they can collapse also. So there is a biggest challenge. So they are already on these drugs. So what is happening to the catecholamines, or whatever drugs that you are giving will not be effective. So that is one group of disease that you need to keep in your mind. But we'll come back to this patient, a 75-year-old gentleman who had an altered sensorium. Now we have done a blood gas analysis and you have found out that sodium is 118. So we are getting a cause, a reasonable cause for his altered sensorium. And what will be the most important reason for an elderly gentleman coming with an hyponatremia?
Drugs.
Okay, it can be drugs, drug related to drugs. Decreased intake, okay. Suppose he had an underlying any fever or anything, the feeds have come down, so he's not taking adequate amount of salt and adequate amount of water, so that might be the reason. Then the most common will be renal. It will be, rather than renal, I will say that it's an urinary tract infection. When you take into urinary tract infection, that is one of the most common reason for your sodium loss. When you traditionally call, you cannot call it as an SIDH also. Because SIDH, to call it as an SIDH, all the systems should be normally functioning. Your thyroid should be normal, kidney should be normal. But when you see, that is one of the common presentation, a patient with an urinary tract infection to develop hyponatremia. Multifactorial. I am not saying it is just the urinary sodium loss. Maybe because of vomiting. Maybe because of the fever, the intake has come down. So that is the another most common thing that we will see. So UTI and hyponatremia, they all go together. So whenever you see a patient with UTI, you can have a patient with hyponatremia, the same patient. Why UTI for a 75-year-old? Prostatomegaly. So elderly gentleman coming to the ED, one thing that you can have is again prostatomegaly. It can be a chronic prostatitis or a benign, just a benign prostatic hypertrophy leading to a urinary tract infection. So you have to keep this thing as your differential diagnosis. So we don't know, an elderly patient has come with an altered sensorium, we are seeing hyponatremia. First thing I wanted to see is why he is developing hyponatremia, and the second reason I would like to assess his prostate and also if he has got a urinary tract infection. This will be my concern for this patient. Okay, so now we can go ahead with the other evaluation.
A sample history. 75-year-old male who is a known case of diabetic dyslipidemia (CAD) with mild systolic dysfunction, presented to ER with altered behavior, irrelevant talk and decreased food intake since 1 week. He was admitted in a local hospital and serum sodium was found to be 107, for which he was corrected, and it became 124. After correction, he was discharged, and as he checked sodium later, it was 117 milliequivalents. No history of fever, chills, vomiting or abdominal pain. Patient had history of acute onset breathlessness, which was treated as pulmonary edema, and he was on thiazide, Telma-H diuretics, which was stopped from local hospital, but the patient had taken last dose even after discharge from the hospital.
Okay. So that is the one of the precipitating factor we have got, because telmisartan with hydrochlorothiazide, telmisartan to some patient they can cause hyponatremia, but definitely hydrochlorothiazide. But when you see majority of the patient, elderly patient, the first line of agent we will start hydrochlorothiazide, but there is always a risk factor of patient presenting with hyponatremia. So that might be the reason for him to develop. They have stopped the medication. Even after stopping the medication, he have restarted it. So that is the reason why he would have developed this. Okay, continue.
On examination.
So now we have a patient. Examination findings, I don't think anything significant. There is no focal neurological deficit. So we have, that's a very common scenario. You are seeing a blood gas analysis. You are getting a patient with a sodium value of 118. So how will you proceed further?
We can send the lab values for the sodium.
Okay, so my question will be, whom all you will start treatment right now?
If it is presenting with any neurological symptoms like seizures,
okay,
or any.
So before that, what will be the symptoms for each level of hyponatremia? You can start off maybe with 130 milliequivalents. Be less than 130 milliequivalents, what will be the symptom? Less than 125 milliequivalents, what will be the symptom? And less than 120 milliequivalents, what will be the symptoms for the patient?
Mainly neurological.
No, it just start with generalized weakness. So everything start with generalized weakness, tiredness, fatigability. That will be something like 125, 130. That will be the patient's presentation. So they will have generalized weakness, tiredness. They won't have any neurological weakness at that point of time. They will be conscious oriented. So once they start falling down below 125, that is the traditional thing that I am telling. Less than 125, they will start developing slightly altered sensorium. Less than 120, the seizure threshold decreases. So at any point of time, they can develop a seizure. So it all depends upon your level of your sodium. So you are saying 118. I am expecting that this patient can have a seizure at any point of time. But again, a blood gas value, there can be an error. But you can always take it as, if you add 10 to it also, it is 128. If you can less than 10 also, it is 108. So if you put it error of 10 also, it is on the lower side. So since he is conscious and oriented, 118 sodium, we know that it is due to a drug-induced hyponatremia. So how will we, as you said, what are the investigations that you wanted to send now?
Urine sodium, serum osmolality, urine osmolality.
Okay.
Urine sodium.
You wanted to send osmolality for all the patients with hyponatremia?
We are suspecting a CR.
Suspecting a?
SIADH.
So SIADH, what will happen to the serum osmolarity?
Serum osmolality will be more.
Serum osmolarity, how much will be the serum osmolarity? Is it more or normal? What will happen to the serum osmolarity? Naveen? I need to shake you and wake you up. Yeah? What will happen to the SIDH? Huh?
Normal to reduce.
It can be basically normal, and see, most of the time when you call it as SIDH, the patient, technically the patient will be looking like eulemic, but there will be some amount of fluid excess. So when you start thinking of hyponatremia, as you know, the three classical things, so depletional, dilutional and SIDH. So depletional, we straight away know that the patient is having vomiting, diarrhea, the sodium amount have come down, or maybe the doctor have suggested them not to take sodium because of hypertension, so they restrict sodium to that extent. So do hypertensive patient need to restrict sodium? No. So what will the advice that you will give? Normal intake they need to go. There is no added salt. They should be avoiding that food that contain excess salt. So that is the only thing. So they need to avoid all the pickles, all the fried items, maybe papad and all those things. So that will be the general instructions. But some patients feel that they have got this hyponatremia and they hypertension, and they stop sodium consumption. So that will be the one of the reasons. So there you will have definitely serum osmolarity will be low. Hypoosmolar hyponatremia. Then to take into dilutional hyponatremia. So dilutional hyponatremia, what is exactly the dilutional hyponatremia? So how does a dilutional hyponatremia happens?
Due to water excess, fluid excess in the body.
Okay, so fluid excess in the body. So sodium level is the same. So sodium level is the same, but there is excess amount of water in the body, like you see in chronic liver disease, chronic heart failure, and renal failure. So these are the three things that you need to remember. And finally, you will have the patient who is having syndrome of inappropriate ADH secretion. So what is the pathophysiology in SIDH?
There is antidiuretic hormone endogenously there is excess.
Excess. So what will happen?
More sodium and water will be eliminated.
Okay. So what will happen to the patient? Sodium?
Hyponatremia.
Sodium will be hyponatremia. So in technically speaking, it is also a type of dilutional hyponatremia only, but you will not be able to see volume excess in the patient. So when you clinically evaluate, clinically there is no volume overload. There will not be any features of edema or anything. But SIDH, when to call SIDH? When you will say, okay, this is SIDH.
Urine sodium is...
What is the diagnostic criteria for to call a patient is an SIDH? I told you, the first thing, all the organs should be normal. That's the first thing. Your thyroid, kidneys should be normal. That is the first requirement to call a patient is having an SIDH. Then urinary sodium, you need to check. If you don't check osmolarity, also fine. I will not, that is okay. Urinary sodium, more than 20, more than 40, definitely you can tell the patient is having syndrome of inappropriate ADH secretion. So SIDH to call, so these are the requirement. Is there, then what you have to say? We cannot just say it is SIDH and you can leave the patient. You have to go back and see why this patient is having SIDH. So what are the reasons for SIDH? There is no idiopathic SIDH. When you look into the textbook, there is no idiopathic SIDH. When you are calling somebody having SIDH, ideally we need to look into the reason why they are having an SIDH. So what are the common reasons to have for an, whoever it is, to have an SIDH?
Any infections, LRT.
Then, malignancy, that is the most important malignancy. So what is the most common malignancy that is attributed to SIDH? Lung, small carcinoma, lung. It is very common to have an SIDH association. Then you need to look in for any paraneoplastic. It's whether it's a paraneoplastic syndrome that is happening because and hyponatremia is one of the feature. Maybe SIDH is the feature of the one of the malignancy that the patient is having. Then brain injuries or anything, that is another reason. Stroke. These are all the reason why you can have SIDH. So you cannot say idiopathic SIDH. When you say SIDH, you have to see what is the cause behind SIDH. So that is the thing that you need to find out. So you said regarding urinary sodium and osmolarity, these are the investigations that you want to send. Any other investigation that you wanted to send in this patient? Any other investigation? See, what will happen to the urine sodium for this patient? Will be? Why? Because of the drug. So that is the one thing when you are calling, you cannot just go and say that this patient is having SIDH. Already this patient is on a diuretic. So because of that, there will be a sodium loss. So the urinary sodium will be technically is going to be on the higher side only. So we cannot just rely upon the urine sodium taken or sent at this point of time. So then how will you treat this patient? You stop the telma-H and whether you want to start 3% saline or not. That is my next question. So rather than I will phrase it, whom all you should start 3% saline. You said the answer. Just
seizures.
Definitely with altered sensorium. Any CNS involvement is there. You need to start on 3%. I am not denying the fact. After this lecture, you should not be starting 3% saline. That is not my idea. You should be selecting the patient correctly, and you should be starting 3% saline for a group of patients whom require 3% saline. So whom all you will start, as you said, altered sensorium. Seizure, no doubt, you need to start the patient on 3% saline. Definitely altered sensorium, drowsy patient, maybe a borderline sensorium patient. You are not very sure whether this patient requires. If he is becoming again and drowsy, you need to start. See, 3% is not only the treatment. You have other treatment options also. I am not telling not to treat hyponatremia. I am telling you to avoid 3% saline in certain situations. So where all you need, definitely you need to start. Like in seizure, yes. Drowsy patient, GCS of around 10, only responding to painful stimuli, very much drowsy, elderly gentleman, yes, no doubt, you have to start 3% saline. So 3% saline you have decided to start. So how will you start 3% saline? That is the question next.
We
So
have
can you just tell me what does it contain? 3% saline, each ml will have how much?
3% saline is a 100 ml bottle and contain 51.3 milliequivalents of sodium, which is 3 grams sodium.
Okay.
Then we have to first find the sodium deficit. So 0.6 into body weight into desired sodium minus the serum sodium now. We have to correct, for acute cases it should be 6 millimoles should be corrected, and
For acute cases, can you
total 6 millimoles.
see the thing is that, for example, I have got a patient with 110 milliequivalents of sodium. So what is the target that you wanted after 24 hours? 110, what is the target that you wanted?
120.
It is an acute hyponatremia, I am telling you, without any comorbidities. He has taken depletional hyponatremia. There are some, he is not taking adequately fluids, he is not taking adequately the salt content, and he has come with an depletional hyponatremia. So it's an acute onset, there is no drug, no comorbidities. Take a stable patient. So his sodium is 110. So after 24 hours, what should be the target for sodium for that patient?
120.
Should be somewhere around 120. So 8 to 10 milliequivalents is accepted for a patient who is otherwise stable and who is otherwise no comorbidities, no other risk factors. So 8 to 10 is acceptable. So my sodium target will be 120 milliequivalents. So for that, to reach that 120 milliequivalents, how will I plan my total deficit you are calculating? You are calculating and finding it out. What will be the total deficit? You want to increase. See, every patient will have the same deficit. It is simple. You are only going to correct 8 to 10 milliequivalents. It doesn't vary. So every patient will have only 10 milliequivalents is what we are going to correct. 0.6 you will put for a male and 0.5 you will put for a female. So all the male and female, the requirement, that's the total deficit. Suppose imagine that the total deficit is 300 milliequivalents. 300 milliequivalents, out of this 300 milliequivalents, I am telling it is depletional. I am telling you it is depletional. Okay. So depletional hyponatremia is what I am telling you. So depletional hyponatremia, out of this 300 milliequivalents, I wanted to correct maybe 100 milliequivalents in the next 24 hours. Imagine that I wanted to correct 100 milliequivalents. That is only requirement to correct. I am just assuming, I am not calculating, just assuming that he requires 100 milliequivalents. So for the correcting that 100 milliequivalents, how will you plan?
One bottle containing 51.3 milliliters.
Okay, so you will give two bottles. Two bottles is that's what you are telling. But again, you have to think that this patient is taking feeds. He might be taking feeds. You will be giving Riles 2 feeds. You will be giving other fluid hydration also, like normal saline. Or that also will contain 3% saline, which just treat the hyponatremia. We have to treat the water deficit also. So for that water deficit, we will be giving normal saline also. So normal saline also will contain some amount of sodium. So whatever the deficit you are planning to correct, each patient you need to take in. So depending upon the requirement of that patient, you need to fix it up. Okay, I wanted to give 20 ml per hour and I wanted to give a percentage of the total sodium by 3%, a percentage by oral correction, and the rest will be managed by your IV fluids. So it is that total requirement you need not correct. That is the total requirement to correct the hyponatremia. So a part of it you can correct it 3% saline. I am telling you this for a patient who is drowsy only. But again, if the patient is having seizure, totally different. I wanted to have an aggressive correction of the sodium. I wanted, maybe I will give the whatever the 100 ml of bottle in maybe in 1 or 2 hours. Even if you give, that is in seizure, you will give 50 ml per hour, maybe 30 ml per hour, maybe one bottle in an hour also there are recommendations. But that is only for patient with seizure. But for those group, what you have to see, closely monitor the sodium. Because in 24 hours, it should not go beyond 8 to 10 milliequivalents. So if you are correcting within 1 hour, 2 hours, that doesn't matter. That is for a seizure patient. So again, you should not be continuing like 20 ml per hour, 30 ml per hour and all. So you have given the required correction and then the additional correction should be done by something else. Either a normal saline or maybe an adult salt. But for a seizure patient, you might need to go a little bit aggressively. That is only my thing that I wanted to tell you. Maybe you can give the 1 liter. There has been studies, they have shown that they have given 1 bottle over 1 hour for a patient with seizure. And rest 23 hours they will not do anything. because they have corrected the hyponatremia. What is required, because they are anticipating that if you give 100 milliequivalents, that 100 milliequivalents is the requirement for the patient, that you do it earlier. Within 24 hours, you are correcting this. So within, that doesn't mean that you cannot correct within 1 hour. That doesn't mean that you cannot correct it within 2 hours. So you should not be repeating that in the same 24 hours. You can do it after 24 hours also. So that is one thing that you need to keep in your mind. So it is always, the sodium correction is multifactorial, not just 3% saline. Added salt will be there. The same patient, we are stopping the drug also. So we are stopping the culprit reason. So that also will cause a decrease in the hyponatremia. So again, the patient will start taking orally. If he is conscious oriented, he will start taking normal diet. You will be giving some hydration to the patient. So with this all, it will correct. But one thing that I wanted, every time when you are correcting the sodium, you check sodium 6th hourly, at least 6th hourly. So we don't know how the water and the sodium act. So it's a tricky thing. Seizure patient also? See, seizure patient, that's what I said. If you are having a patient with 110 milliequivalents, okay, 110 milliequivalents, he develops seizure. I'll give maybe 50 ml per hour. I'll wanted to get the sodium corrected aggressively. But I am not crossing the target of 8 to 10 milliequivalents in 24 hours. I am doing it a little bit faster. I am not crossing the limit of this patient. Okay. So that is what you need to understand.
In that case, we wait for 6 hours for soda repeat, or we do in 2 hours or in seizure patient.
We have to repeat every 6th hourly. If it is again coming down and if the seizure is persistent, you need to increase the correction and you need to look for the other causes. See, you have to remember that 110 milliequivalents, you have given the 100 milliequivalents correction, or imagine that you have given 200 milliequivalent correction. What is required for the next 24 hours, you are given within the first 4 hours. If again the patient is developing seizure, usually after giving this correction, the sodium will be approximately nearing 120. So that the seizure threshold will be low. But if it is not, if it is due to hyponatremia, 120 milliequivalents should not cause a seizure. If it is due to some other reason, you have to go beyond that. And you need to check sodium 6th hourly for that patient also. 6th hourly, not very frequently. Yeah, no, 6th hourly should be okay for that patient. You just give the sodium and correction and check the sodium 6th hourly. If it is again coming down, then you need to correct. Okay. So that is what you need to remember regarding sodium correction for a patient with severe hyponatremia. That is, I am saying, irrespective of the cause for hyponatremia, whether it is depletional, whether it is dilutional, or whether it is SADH. But in certain group of patients, I will be saying you just start at 6 milliequivalents. 6 milliequivalents is only I wanted to correct. Which are the group of patients? Chronic alcoholics, starvation patients. You will have multiple factor deficiency, nutritional factors deficiency. Who's chronic hyponatremia group of patients, I don't want an 8 milliequivalents. I just wanted a 6 milliequivalents corrections only. So when you are starting the hyponatremia, 1, 2, 3, 4, 5 questions. First reason why this patient is having hyponatremia. Whether I need to correct with the 3% saline. Whether when you need to correct with the 3% saline, definitely a CNS involvement, or an high threshold patient, whether you feel that he will go in for a seizure. Third, what type of hyponatremia he is having. Fourth question that what will come in your mind, whether it is chronic or an acute hyponatremia. What are the associated comorbidities for this patient? So these are the things that you need to consider. So if the patient is an acute hyponatremia, 10 milliequivalents, okay. Chronic hyponatremia and nutritional deficiency, you just wait maybe 6 milliequivalents, very slowly only we need to correct. So otherwise, this group of patients can go into a pontine myelinosis. So that is a complication. Why I am saying this right now, like previously they used to tell you can go for 8 to 10 milliequivalents even for chronic hyponatremia, 6 to 8 milliequivalents. But now, even with an 8 to 10 milliequivalents corrections for a patients with thiamine deficiency, chronic alcoholics, even 10 milliequivalents is only been corrected in 24 hours. There has been case reports, they have gone for pontine myelinosis. So you have to be very, very slow in this chronic group of patient. Just don't jump and start 3% saline. You can start 3% saline maybe with a very small flow rate. Maybe 10 to 15 ml per hour, 10 ml per hour, and check sodium very frequently if you are getting the desired result. Because 24 hours I wanted only 6 milliequivalents. After one bottle itself it has increased to 6 milliequivalents, just stop it. So that is how we'll get an idea how the body is responding, because sodium is always dependent upon your water balance also. So water balance is one thing we cannot predict in the body. Water balance is very difficult to predict. So we would have given some injections. So by the time some fluid would have gone inside, some antibiotic would have gone inside. So water balance is very difficult to predict. So in this group of patients, very, very slowly you correct the sodium. And next important thing is that when you have a patient with dilutional hyponatremia, very common in ED, you will see dilutional hyponatremia. Somebody is coming and saying, sir, sodium is 160. So 116, so what will you do? You will start correction or not start correction? We will wait. Personally, if you ask me, I will wait for the patient. If he is having altered sensorium, as you asked me before, hepatic encephalopathy patient with altered sensorium, whether I should correct the sodium or not. That's a big question. No one in the world can exactly answer this question, whether the altered sensorium is due to hyponatremia. You need to assess the patient. You are getting any other risk factors for an hepatic encephalopathy. There are flapping tremors. There you feel that there is a precipitating factor like constipation. Then you think it is more in favor of a high hepatic encephalopathy. There is nothing else. The patient was all right, but today suddenly he has become drowsy and seizures. Hepatic encephalopathy, to get seizures, they will get seizures. Grade 3, grade 4, they can get seizures. But hyponatremia will be more suspicious to cause a seizure with a 114 milliequivalent. Suppose the same patient is going to get tapped. Ascites they are going to remove. So definitely, automatically the hyponatremia will improve. So that's again a tricky question. So tricky patient. So we have to be very, very slow in correcting this patient. We cannot say that you give 10 milliequivalents, nothing will happen. Anything can happen to this patient. So if you give 20 milliequivalents in an hour, the sodium can jump from maybe 114 to 116. Meanwhile, they would have done some tapping also. So they have removed some amount of fluid, and patient would have started taking orally. So all these factors will be need to be considered. So again, dilutional hyponatremia, what do you need to do? Remove the fluid. That should be enough. You have failure, you give more amount of diuretics and remove the fluid. Then the next thing is it's SAADH. So you diagnose an SAADH. So I am saying that you should find out a cause of SAADH. Majority of the time, it is very difficult to find a cause for SAADH. It is difficult to find a cause. Maybe you need to do a PET CT and all, who is having frequent hyponatremias and all, to get a small lesion in the lung and all. But once you get an SAADH, what do you need to do? The first thing, fluid restriction. You restrict the fluid. There has been incidents where the fluid has been restricted to 1 liter per day, 750 ml per day. So that's the first thing, you do a fluid restriction. Then the patient is symptomatic. You need to correct if hyponatremia is severe, but otherwise you can start on Vaptans. Vaptans are the drugs that tolvaptan is the one commonly used drug. And before you start tolvaptan, just see that LFTs are okay. And you start maybe 15 to 30 mg per day to start off with. And you check the LFT and you check the desired sodium. So if the patient is getting a desired sodium, okay, well and good. You can continue maybe OD basis, maybe alternate days. And what is a real SADH? They need to continue for a longer time. But if it is not a real SADH, maybe something mimicking like an SADH, most commonly is an UTA. Maybe after 2 to 3 weeks, you will be able to stop your tolvaptan. So that is your SADH. So depletional, you treat both fluid as well as your electrolyte. You are dilutional, you remove the fluid, and for SADH, Vaptans is the treatment. So anything else that you want to add? So at the end of the day, you should not stop using 3% saline. I am not saying to stop. You have to answer these questions. Answer these 5-6 questions, whatever I have said to you. Then you come to a conclusion whether it's a stable without any risk factor patient, no problem. But always make a habit of checking sodium 6th hourly. We don't know. Why I am saying is that somebody can, why not sodium 4th hourly? Yes, you can check 4th hourly. But we cannot say that every hour to check the sodium. We should have a protocol. At least 6th hourly is the thing that what we have changed. You see the guidelines, maybe many of the guidelines may not say to check the sodium, but they will just put a word, check sodium frequently. How frequently they will not say. That all come with your experience. You see, start seeing more and more patients, then you will get an idea. So 6 hours is a reasonable time that whatever the changes that going to happen will happen within the 6 hours. So just keep an eye on it. So whenever you start a 3% saline, you use this. That is the hypotonic saline. Added salt, yes, 8 to 10 grams of added salt that you can give. So if you give 8 to 10 grams of added salt, how much sodium it will increase?
3 grams, 51.3. So
just imagine, it's a huge amount of sodium. It's a huge amount of sodium. Added salt, thinking that added salt is don't think that added salt is an inferior thing. Added salt is also a superior thing only. But the problem is that the added salt, whatever you're giving, is not the exact only salt. It will have other composition. So it will not be that concentrate like a 3% saline. Okay, fine. Thank you.